Good morning, everyone. Thank you for joining me this morning. Just to let y'all know, this webinar is being recorded. I am going to unmute you all for a moment just to say hello, and I want to make sure you have visual. You are
I don't know.
Pardon?
I'm sorry. I don't know if I have visual. I really don't want people to see me. I'm in my
Oh, no,
big
not
space.
visual of you. Are you able to see what happened on your monitor?
But yeah,
Okay, yeah,
I'm,
no, we don't.
I'm not technically savvy, Danielle. This is Yolanda. So.
All right, but you guys can all see the screen, the monitor just fine? I don't want to get started and still have that blocked. Okay, so I'm going to go ahead and get started. I'm going to put everybody on mute just to help take away from some of the background noise. However, at the end of this webinar, we will have an opportunity. I will unmute you all. You'll have an opportunity to talk. If throughout the webinar you wanted to put something in the chat box, please do. Just be advised that I am alone. My counterpart is attending the Mental Health Services Oversight and Accountability Commission meeting today. So I won't have a second set of eyes to read the chat box as we go, but I will review it at the end and hopefully have an opportunity to answer all your questions, okay? All right, let's go ahead and get started. So don't let the name fool you on the chat box. My name is Andrea Crook. I am using Danielle's account. And today, thank you all so much for joining me. We have a lot of information to cover. I'm going to go ahead and just dive right in. So I want to let y'all know, you may notice we went through a name change recently. So we are still a continuation of NorCal, Mental Health America, but we've changed it to be, our name to be Cal Voices. We have been doing statewide advocacy work for well over a decade, and we just thought it'd be time for us to have a name that matches, the work that we do, and we're not confusing our Southern region partners. And our organization was founded in 1946. We are the oldest continuously operated peer-run consumer advocacy agency in California. And we are an organization that specifically hires individuals with lived experience. Access California, Access for short, is a program of Cal Voices. And we are a consumer-led statewide stakeholder advocacy program. We are funded through Prop 63, the Mental Health Services Act, and we have oversight of our contract through the Mental Health Services Oversight and Accountability Commission. Okay, I am going to unmute y'all just for a moment because I am seeing, hold on one moment. Can you all see your monitor? Are you seeing the slides?
No.
No?
We're not seeing.
Oh my goodness. Okay, Can you now?
Yes, we can.
Okay, all right. Sorry
now
about that.
I can. Yeah.
Asking earlier, I thought she was saying you could see it, but okay. I want to make sure now. We all have visual.
Yeah.
Yes?
Yes.
Yes.
All right. Thanks for the I'm glad I caught that. All right. Thanks so much, Pamela.
You're welcome.
I'm going to go ahead and go back. And mute, but I will do my best to keep an eye on that chat box. Okay. So ACCESS stands for Advancing Client and Community Empowerment through Sustainable Solutions. And our mission is to strengthen and expand local and statewide client stakeholder advocacy in California's public mental health system through individual and community empowerment. So our values are advocacy, recovery, and peer support. And when we talk about advocacy, we're talking about ensuring that there's meaningful stakeholder participation and active solicitation of community feedback, as well as expanded opportunity for involvement and inclusion at all levels. So we want to ensure that we have individuals with lived experience in public mental health system that are helping to drive and shape policy development, program planning and implementation, as well as service delivery and oversight and administration. When we talk about recovery, we're really talking about the infusion of recovery principles in all aspects of service delivery, as well as ensuring that there's ongoing meaningful recovery-based training for mental health professionals, as well as we're tracking recovery outcomes in an ongoing, on an ongoing basis for all mental health programs. And peer support, and we want to ensure that there's fidelity to the evidence-based model and that peer support is being expanded upon across the state, as well as peer providers are being provided a living wage and ongoing professional development, as well as opportunities for advancement. So these are not only our values, these are also our annual themes. You will find our State of the Community report for year 1 was all around advocacy, and we just released our year 2 report, focus on recovery and meaningful recovery outcomes. And this year we're really drilling down into the peer support. So what's so special about the MHSA? So this is why you all joined us today. So the first and foremost thing that everyone needs to recognize is that the Mental Health Services Act is not increased funding for the old mental health system that we have known for the past decade. Instead, it is a complete transformation to a new system. So this was Rusty Seelix and Daryl Steinberg. They are the co-authors of the Mental Health Services Act. And they posted this as well as DMH back in 2005. And in your attachments, you'll find I provided you with the full documents for your viewing pleasure. So DMH goes on to say that funding provided through the Mental Health Services Act will be used to transform the current mental health system from one that focuses primarily on clinical services into one in which county mental health programs can enter into partnerships with clients, their families, and their communities to do and to provide under client and family direction whatever it takes to enable people to obtain their goals. So what happened to the MHSA? So if the MHSA was intended to transform the public mental health system through community collaboration, ongoing stakeholder involvement in program planning and oversight, client-driven and recovery-oriented services, as well as integrated mental health and social services, and create a stable source of funding dedicated to recovery-based mental health services that was independent from realignment funds and the state general fund, as well as Medi-Cal, why is so little of this actually reflected on the state and county levels today? So after doing comprehensive research and studies over the past couple of years, really in the recovery model that MHSA was supposed to be all encompassing, we started kind of scratching our heads and saying, well, what happened? And so what we did is extensive research on back to 2003 and 2004 and 2005. 2005 was the first year we started implementing this to kind of see where were there any breakdowns that we can learn from. And so what we discovered is that there were 3 major factors. So we had one, a fragmented oversight authority. We had then phased implementation, such as non-integrated MHSA plans and MHSA funding backlog. And then, of course, as we all know, we had the Great Recession. So I'm going to take the rest of our time together to kind of drill down into this a little bit more. And I think that this will be meaningful for you all to know and to be able to share with your local communities. So fragmented oversight. So The Department of Mental Health was given the lead state role in implementing most of the new programs created by the Mental Health Services Act and allocating funds for those programs through contracts with counties. The Department of Healthcare Services picked up the oversight responsibilities after the governor and the legislature dismantled the Department of Mental Health back in 2012. A new OAC, Mental Health Services Oversight and Accountability Commission, was created in 2005 to review county MHSA plans and approve programs and expenditures for certain programming components. And the Mental Health Planning Council, and it's now called the Behavioral Health Planning Council, would continue to review and oversee and review the state's mental health system and outcomes, including those for the Mental Health Services Act programs. So the Department of Mental Health had approval authority over CSS, WET, capital facilities and technologies, prudent reserve, and the community planning process components in counties, MHSA 3-year plans and annual updates, and had advisory authority over counties for prevention and early intervention and the innovation components. So DMH was responsible for enforcing county compliance with all MHSA fiscal mandates. However, the OAC had approval authority over prevention and early intervention and innovation components in counties, MHSA 3-year plans and annual updates, and they had advisory authority over community services and supports, workforce education and training, capital facility and technology, prudent reserve, and the community program planning components. So then the Planning Council would help create the evaluation metrics for MHSA programs and review and report on MHSA program outcomes. However, only the Department of Mental Health could sanction counties for non-compliance. So even though we had oversight authority and approval authority in other state departments, if counties weren't aligning with the MHSA plans, DMH was the only one that could sanction them for that. So the consequences of this were tasking multiple agencies with MHSA oversight created great confusion and procedural inefficiencies, as many MHSA functions cannot be performed in isolation without creating duplicative and potentially conflicting processes. So only one agency, DMH, which now DHCS holds their authority, was granted the authority to actually do something if counties aren't complying with the Mental Health Services Act, and the other agencies must refer compliance issues now to the Department of Healthcare Services and hope they get resolved. So shared responsibility has led to the diffusion of responsibility and the assumption that no personal action is needed because the other party will handle it. So then we move on to phased implementation. So the Department of Mental Health thought that the MHSA was too complex to implement all at once. So it therefore decided to implement the Act in phases. So the Department of Mental Health issued guidelines for the MHSA's various programming components in the following stages. So in 2005, they issued guidelines for community program planning process and CSS. And in 2007, WET and PEI, and in 2008, capital facility technology and innovation. So when we look at the guidelines for the community planning process and the community services and supports, it's really interesting. I actually, have been doing trainings, a lot of trainings in all the regions throughout California for the last couple of years. And everyone's saying, we had such a robust CPP back, in 2005 when MHSA first rolled out. Well, it's interesting. If you look at the guidelines issued to the counties, when they had to originally apply for CPP funding, I attached that document for you. This is what the states was requiring of counties. And it's our belief that this isn't being reviewed at the state level on an annual and 3-year basis. So that's one another issue I just wanted to bring to your attention that you can review. But the document that I'm talking about, it's attachment A. It says required contents, county funding requests for mental health services at community program planning. This is really a meaningful document that you can take back with you to your communities and use as a guide and a template for your community planning process. All right, so I'm going to get back into the phased implementation. So we also identified 2 significant consequences which arose from this decision to provide phased implementation. And this was a non-integrated MHSA plans, as well as a backlog of MHSA funding. So the MHSA requires counties to develop integrated plans for prevention, innovation, and system of care services. So counties are supposed to develop plans for all MHSA program components as part of a single, comprehensive, internally consistent 3-year program and expenditure plan. An integrated plan means that the programs for all the MHSA components are developed to be fully cohesive and interdependent of one another to meet an overarching vision for the public mental health system. And the consequences of this phased implementation did not consider the final MHSA plan integration. And the Department of Mental Health offered counties no guidance on how to integrate the various MHSA programs initially created independently of one another into one plan. And phased implementation was not in compliance with the MHSA and contributed to an inefficient process. And to this day, counties are facing challenges with harmonizing all of the MHSA components in their 3-year plans, as well as their annual updates, as was originally intended under the MHSA, resulting in siloed programs and services. To ensure counties could only spend MHSA funds on specific programs and activities authorized by the Act, the MHSA laid out detailed requirements that counties must meet to receive MHSA funding from DMH. And we do believe that a lot of this was a factor into creating this huge MHSA funding backlog that we're seeing still today. So first, counties entered into agreements with the Department of Mental Health to provide MHSA authorized services. Next, counties developed their 3-year program and expenditure plans and submitted them to DMH for review approval. And once the Department of Mental Health approved the plans, it released the MHSA funds to the counties to implement the programs and activities identified in their approved plans. So pretty much agreement plus an approved plan equals you'll get your MHSA dollars to your community. So phased implementation staggered the release of the DMH guidelines for each MHSA component over a 3-year period. So through 2.5 and 2.8, counties were just waiting on the guidelines for each of the components. So counties couldn't develop their component plans or get funds for these components until DMH released the guidelines. And instead of being able to submit one integrated plan to DMH, as was intended by the MHSA, counties had to submit 6 separate plans to DMH, which was labor-intensive, time-consuming, repetitive, redundant, and took several years. So then DMH process for reviewing and approving county submitted plans was inflexible, lengthy, and inefficient. So the consequences of this are because counties couldn't get the funding until DMH issued component guidelines and approved their component plans, a lot of the money accumulated at the state level and didn't filter down to the counties for programs and services as originally intended. So by March 31st in 2008, so about 3 years after the money started rolling out, there was $3.2 billion in MHSA revenues that had been collected by the state. $2.9 billion had been allocated for county use. $1 billion had been approved for distribution to counties, and only $726 million had been distributed to the counties. So less than 23% of the revenues that had been collected by the state had actually been disseminated to the counties by 08. So to expedite the flow of the funding to the counties, the Department of Mental Health began paying out 75% of counties' allocated MHSA funds in advance prior to reviewing and approving their MHSA plan and update. So they were just trying to get the money out to them, you know, trying to expedite it in any way they could. But this expedited process did not completely resolve the accumulation of unspent MHSA funds at the state level. Then we had the Great Recession. So the bursting of the US housing bubble in 07 caused a national and global financial crisis dubbed the Great Recession. This was the most severe economic downturn in the United States since the Great Depression of the 1930s. So the Great Recession created a statewide budget deficit in California of over $57 billion in 2008, resulting in massive budget cuts to state and county agencies and double-digit unemployment rates. So we know what else was happening in 08, right? We had mass accumulation of MHSA funds at the state level, right when the Great Recession hits, and it was an easy target, right? So the Great Recession's effect continued into 2011, resulting in California legislature's passage of $27 billion in budget solutions. So also known as long-term measures to increase revenues and reduce expenditures that included restructuring funding mechanisms for state and local services. So it's known as realignment. So there were three significant consequences that we want to touch on from the Great Recession. We have Mental Health America of California versus Arnold Schwarzenegger, our governor, in 2010. Assembly Bill 100, Realignment in 2011, and the Dissolution of DMH in 2012. So in 2005, the Department of Mental Health issued guidelines to counties on the Mental Health Services Act, non-supplantation, and maintenance of effort requirements. So they stated, you know, as says the Welfare and Institution Code, that MHSA funds can only be used for programs authorized by PEI, CSS, all the funding components. MHSA funds cannot be used to replace other state or county funds required to be used for mental health services in fiscal years 04-05. MHSA funds can only be spent on programs that were not already in existence in the county at the time of enactment of the MHSA, so new programs, or to expand the capacity of existing services being provided at the time of the enactment. So they can expand a program or create a new program. In 05, the Department of Mental Health issued guidelines to counties on the non-supplant and maintenance of effort requirements. However, counties could stop funding mental health programs that no longer met the needs of the county and its stakeholders, as long as the aggregate state and county funds required to be used to provide mental health services are used for such purposes. So just to touch on that, again, that's maintenance of effort. So counties can't go below, investing below how much they had dedicated back in 04, 05 to mental health services, behavioral health services. So because of the budget deficits created by the Great Recession, in August of 07, Governor Schwarzenegger exercised his line item veto authority to delete almost $55 million in the 07-08 budget for AB 2034 programs. And his argument was that while I support the goals of the program, this reduction is necessary to limit program expansion and to help bring ongoing expenditures in line with existing resources to the extent counties find this program beneficial and cost-effective. It can be restructured to meet the needs of each county's homeless population using other county funding sources such as federal funds, realignment funds, or Proposition 63 funds. So there you have it. Then Mental Health America of California sued Arnold Schwarzenegger's administration, arguing that defunding AB 2034 programs violated the MHSA non-supplantation and the maintenance of effort requirements, because the MHSA says that 0405 funding levels must be maintained for all mental health programs and services that existed at the time the MHSA passed. AB 2034 programs existed when the MHSA passed, right? I mean, that's why we have an MHSA. It was modeled after these programs. Therefore, the 0405 funding level for AB 2034 programs must be maintained. The trial court ruled that defunding AB 2034 did not violate the MHSA. MHAC, Mental Health America of California, again, that was the co-author. He was the director of MHAC, Rusty Seelix, and they appealed the appellate court, but the appellate court ended up upholding the trial court's decision. And they did so, and said they did so because the MHSA did not promise that every mental health program that existed in 04 would be funded in perpetuity if voters approved Prop 63. It promised that the aggregate funding for all mental health programs would never fall below the maintenance of effort, the 04-05 fiscal levels. So as long as the overall budget for mental health services does not fall below the fiscal year 04-05 funding level, the state or county can cut whatever individual mental health program it wants to. The consequences of this is counties immediately began cutting all realignment funded mental health programs that were not Medi-Cal billable and refunding these programs using MHSA dollars. Counties then used the savings and mental health realignment funds to expand programs that were Medi-Cal billable to draw down more federal financial participation, so more dollars from the federal government. Over time, counties saw the advantages of using MHSA, community service and support funds from Medi-Cal billable services to further draw down federal financial participation dollars. So AB 100 realignment. So due to the ongoing budget shortfalls created by the Great Recession, the legislature passed a new realignment package in 2011, which increased county funding responsibility for mental health managed care and other mental health and social services. The realignment package also included a one-time transfer of $184 million of unspent MHSA funds to be used in lieu of money from the state general fund to support county level implementation of mental health managed care programs. So although the final budget package did not specify ongoing realignment allocation, the governor's plan was for the realignment revenues to substitute for the MHSA funds for mental health managed care programs on an ongoing basis, beginning in fiscal years 12-13. The consequences of this is DMH's phased implementation process was too slow in allocating MHSA funds to the counties and left billions of unspent MHSA dollars accumulated at the state level. This made it an easy target for the legislature so that they could use it for its 2011 realignment package. While MHSA funds must be used for new or expanded mental health services, the legislature made a colorable argument that using unspent MHSA funds to implement new mental health managed care programs served this purpose. Transferring responsibility for the mental health managed care programs to counties created an ongoing fiscal burden that counties are allowed to offset with MHSA funds. This reinforced counties' use of MHSA funds to draw down Medi-Cal federal financial participation and pay for programs not originally intended under the Mental Health Services Act. It's really important that we pause and we look at those accumulated dollars at the state level It's an easy grab for the legislature, and I feel that with everything that's going on today with talks of an MHSA refresh, we are at risk of having a lot of changes that a lot of consequences due to these actions. So we want to learn from our past and make a stronger tomorrow. So as a result of the Great Recession and California's ongoing budget deficit, Governor Brown's proposed budget for fiscal year 2012-13 included a comprehensive package of additional efficiencies with reorganized state government to eliminate and consolidate agencies, departments, and programs, and eliminate unnecessary boards, commissions, and advisory groups. So the governor considered the Department of Mental Health a redundant state agency and decided to eliminate it. The legislature ultimately approved the elimination of the Department of Mental Health, which dissolved in 2012. As a result of the Department of Mental Health's dissolution in 2012, the Department of Healthcare Services assumed responsibility for the administration of various MHSA programs and financial oversight of the Mental Health Services Act funds. OSHPD was given the Mental Health Workforce Education and Training Program, which is including statewide MHSA WEP programs. And the OAC became responsible for MHSA training, technical assistance, and program evaluation. Again, in your handouts, you will find all of these documents if you want to further explore and have more to reference. The consequences of the dissolution of DMH was resulted in a huge loss of institutional knowledge and expertise related to the MHSA's vision, purpose, values, goals, and mandates, and halted the forward momentum of the MHSA system transformation. The transfer of MHSA oversight to DHCS exacerbated the shift in MHSA funding priorities from a recovery-based service and integrated care to medical model services and maximization of Medi-Cal FFP drawdown. The reassignment of MHSA-related duties amongst numerous state agencies reinforced the MHSA's fractured oversight and further diffused responsibility for enforcing the MHSA mandates. So the consequences, according to the Little Hoover Commission report in 2016, they stated the mental health program within the Department of Healthcare Services is overshadowed by the state's massive Medi-Cal program, and oversight of the Mental Health Services Act is minimal. They also said the Department of Healthcare Services does not analyze the data reported by counties to verify whether they spent MHSA funds as originally proposed and reviewed and approved. And if a county is found out of compliance with the Act, the Department of Healthcare Services prefers to phone the county's mental health director and prompt them for corrective action instead of issuing administrative sanctions. The Little Hoover report goes on to say that the Mental Health Services Oversight and Accountability Commission lacks authority to help counties correct deficiencies in their MHSA plans or enforce changes to comply with the law, as well as the state law does not require any state agency to review, analyze, and summarize information contained in all county MHSA plans and ensure counties are spending the MHSA funds as they said they would. So let's talk about it. I am going to give this a try. Feel free to use your chat box as well. I'm going to unmute you all. But what thoughts and feedback do you have about this information?
What they have over there.
So you don't necessarily have to answer any of these, but we really want you to ponder these questions and let us know if you can think of any other factors that may have contributed to the current state of affairs. And also, what can be done to ensure that the state and counties maintain fidelity to the Mental Health Services Act original vision for system transformation, community collaboration, and recovery-oriented services. You know, we really feel the MHSA is a powerful document and was written beautifully. We just haven't enforced it the way it was intended. We haven't rolled it out today. It wasn't given a fair shake. And so we want to go back to the basics, and we want to ensure that the vision and the values of the MHSA are not watered down. Are there any comments, feedback?
I have a comment.
Yes.
So after boot camp, I brought to their attention again. They got a consultant, Andrea, and they were just presenting it as giving feedback. But when I brought to their attention, it's an expenditure plan. They weren't comfortable with how that I really made it. I had them post the access general standards, and they weren't comfortable with that. But it's a budget plan, and like Lorraine knows, it has to be district specific because they have not been serving, they have not been inclusive. So by having this background of what it's supposed to do and how it is with the money, that it is not county money, it is not federal money, and it's allowing them to see things clearly. And they asked, how can we work with you better? I said, work with the plan and make it district specific and culturally relevant for the communities, because not only do we have to do a state specific, but we have to do a district specific to really have to make sure that the money is invested so that we can see buildings, so that we can prevent it from Steinberg using it just to deal with the population that they call homeless. So it's the quality and the inclusiveness. So you've helped me to be able to speak language to them that it's a 3-year expenditure plan, not a mental health service act, because they don't understand what that means, and they really can't do that as a prevention. They're a component. That's why even when we went to the state, I stated that it can't be done by the providers. It can't be done by the prevention and early intervention coordinator. So we have to do more in giving this framework that it's an actual expenditure plan, not a Mental Health Service Act feedback plan. It's our money, and it needs to go where it has never been before, and it can't be measured or evaluated because we never had the budget language to speak to truth to power.
Thank you so much for that, Pam.
This is Yolanda, and I just wanted to say that because everything's so fragmented, that a lot of the oversight is going to be the responsibility of the various board of directors and commissions in every county, and that the training for the board members, because I'm going to be taking this training to my board, is imperative so that we really understand the history and what's coming down, and we can work better with our board of supervisors and with our behavioral health departments.
I can't agree with you more. Thank you for that, Yolanda. Thank you.
Hey, this is Andrea. I just wanted to say, I think one of my questions I'd like to put out there is, like, how do you, like, so in my county, I feel like the county really enjoys the lack of oversight because they feel like they can get things done and more appropriate to our county without having that oversight, and they prefer it. So when I bring up these issues, there's a real pushback with my director, and they liked the fact that when they want to, when there's an oversight issue, they just call the director. The director likes having that that authority to make those changes in the county, on the county level, because it seems easier and more efficient to get it done in a small county. if you don't have to deal with the oversight of the state. So I'm wondering if there's alternative thoughts on that of like, how can we keep them accountable, but also keep things running efficiently?
Thank you so much for that, Andrea. I'm going to open it up to the group and then I have some feedback.
I'm educating our Board of Supervisors, speaking with their staff and asking them to consider questions about how our MHSA process is not happening as it should. And I even went so far as to say to one of the supervisors' staff, well, why don't maybe the Board of Supervisors could refuse to approve the plan? And she thought that was unrealistic. But I'm actually getting to the point where I'm wondering if approaching the issue with our counties is going to make any difference, or if we need to spend more time, you know, on a statewide advocacy basis.
Anyone else?
Can you hear me, Andrea?
I'm sorry?
Can you hear me? This is Bianca.
I can hear you.
Okay, good. Based on what you just said, it sounds like, and I would have to listen to the, to be honest, I have to listen to the audio again because there's a lot of dense information. I just want to make sure I captured it properly. And I liked, but definitely, I believe that there should be some kind of quality control practice implemented where if we already see that the governor at the state level ended up eliminating some funds from Proposition 63 and using it elsewhere, obviously this is a risk that could happen again in the future. Hopefully it doesn't, but regardless, we need to be prepared for that situation. I think they should be something like you know how whenever we are planning for an earthquake, we have like a emergency, you know, bag, and in the event that happens, this is what we would do. So we should have something like that. I'm thinking that we should have something like that because we can't be bailing out other deficient funds in taking away from Proposition 63 and funds and then using it elsewhere, because then here we go again. The purpose why Proposition 63 was created was so that we have a safety net for the consumers. So if I mean, this is definitely above my head because I'm not a financial person, but this has to be brought up to their attention so that they're like, I just find it interesting. And as an analogy, when I was going to college and there was a budget cuts, I found it interesting how students were not able to go to schools. Teachers were, there was a cutback on teachers, but yet we had all this funding that was not allowed to be touched to create buildings. And so like construction didn't suffer any, I didn't see any of that. They didn't experience any of the repercussions from the downturn of the economic downturn. So that's it on my end. Thank you.
Thank you, Bianca.
This is Yolanda again. And when I heard you speak at the Stockton CalBH meeting class, Andrea, Jenny and I took back to Siskiyou County the fact that we reported to the Board of Supervisor what was happening with CPP, et cetera.
Yeah.
That if what really struck home, and trust me, our directors really stepped up towards this, is that we got to review, that we were supposed to review any projects they were involved in. And if we didn't like it, we could write a dissenting report, and they had to include that in their annual report to the Board of Supervisors. And we really emphasized this to our board in front of our Director of Mental Health, Behavioral Health, and they immediately stepped up and started doing what they were supposed to do. So that if you let them really know that you really understand what's going on and that you're willing to write the dissents, and that if they're not included in the report, you will present that to your board of supervisors saying they did not include this dissent in their report.
Thank you.
Or approvals. And it really makes a huge difference to anyone who's having problems with their mental health director.
That is
Mhm.
awesome,
Thank
Yolanda.
you.
That's wonderful. And I want to tell you that, you know, this DMH document that you have for the required contents for the CPP, I mean, we keep going back to the community planning process, because that's one of the most revolutionary things about the Mental Health Services Act is it
Mhm.
calls for unprecedented numbers of stakeholder involvement. And it calls for a client-driven, family-driven on the U-side systems. And this really goes into more details on what the state is calling on, as well as other stakeholders in the communities that need to be at the table. So I just think that it's going back to the basics. It's really good to have that historical information and to ensure that, you know, the laws haven't changed. This information is still a requirement. Our behavioral health directors have to sign off that this is taking place.
Yeah.
Important that our communities, our stakeholders, our boards, our commissions, our supervisors are aware, and our directors. I mean, there's been so much turnover in their defense. There's so much, there's so many new individuals that weren't here back in 04, 05. So it's an opportunity to really help raise awareness and to do the right thing. I encourage you all to make copies of that. If you haven't downloaded it yet, please do.
Mm-hmm.
And Andrea, it goes back to your input as well and your question. I think, you know, one of the things, and I do think that, you know, it takes a village, and back to Yolanda talking about, you know, boards and commissions really need to feel empowered and educated and have a
Yes.
voice in ensuring, but we need to keep in mind that there are funds available, and counties need an infrastructure where they have funds where they are providing financial support to the stakeholders to be able to meaningfully participate, and an ongoing way. And this goes on throughout the year. And these plans, there are annual updates every single year. A new year, 3-year plan every 3 years. And so the community planning process needs to be meaningful and ongoing, and that means the counties have to have a individual or a unit dedicated to supporting the stakeholders with that. And you know, we need to really push to see that that's taking place, and that we're not putting the full task on volunteer bodies.
Andrea,
Right?
this is Tricia. Can you hear me?
I can.
So I am so grateful for this information. My head's spinning a little bit with all of the information, but I'm glad that we have backup that I can print out and take to the meetings. I'm trying to get a meeting with our director of behavioral health. He is a new-ish director, less than 2 years. He seems to be pretty open to having discussions with me, in addition to me attending their board meetings. So I don't know how aware he is of all of this, but I'm grateful to have this information to arm myself as I go into these meetings.
Yeah, it is dense. It is a lot of information, and definitely, I mean, we're forever learning and trying to wrap our heads around this, right? But this webinar is being recorded. We are going to post it to our website as well. So if you wanted to listen again, and the handouts will be available to you as well.
That's great. Thank you.
I think I saw another hand up. Vernon, you're on. Vernon? Okay, we'll come back to you. Is there anybody else?
Vernon put on the chat, this is Yolanda again, can we form a county oversight collaboration committee with county staff and consumers. Would that be something we would have to take to our county legal
Well,
if
every
we wanted to do
county
something?
have a oversight meeting. And the oversight meeting and again, it's in the document that I provided in the handout that refers to the community planning process. So it says the community planning process must include, and this is also in the welfare and institution codes, active participation by stakeholders in the county if it is to be effective and inclusive. With that requirement in mind, counties must required to provide the following. So besides consumer and families, because consumers and family members are absolutely required, they're mandated to be there and to have a voice. Counties must also require participation in local plan development by the following stakeholders. So providers of services, law enforcement agencies, education, and social service agencies. They also go on to include a ton of other, mental health boards and commissions, housing, employment, criminal justice, senior service providers, homeless service, veteran groups, foster care. So there's a whole host of lists. It's not all encompassing because every community is unique. And so it may not take into account some stakeholders that are really important to certain communities throughout the state. But counties are required to have comprehensive representation for oversight and planning purposes. So the short answer is yes.
Thank you. The other question I have, this is Yolanda again, I'm sorry.
Yeah.
What I was thinking is, one, we actually have as a requirement, though they're not, we don't count it against them if they don't attend, is that one of our members on our board must be from the Board of Supervisors.
Yes.
So that they take all that stuff back. We also provide.
They are your link.
What? We're very unique. Oh, well, and we kept it in our bylaws because we revised our bylaws last year. Oh, what a joy. Okay, and one of the other things that I think is really important for commissions is that we work together. One of the things we're doing is we're taking all these stakeholders, criminal justice, because we do have a problem in Siskiyou County with that, and all the other stakeholders, the resource centers, et cetera, and we have them come to our meetings and make a presentation how they work so that the board members can ask them and we can learn more about all these contracted other agencies that work with us. So we're doing the family community resource centers. We're doing, we've done the homeless coalition, which HUD is now making another board of supervisor appointee type group so that you can get your funding, especially with your point in time count. And education, etc. So that, and we have 3 service providers on our board, which is really nice because they bring a whole new aspect. When we get lost on a mental health issue because we don't even understand the diagnoses, oh, they're fantastic input. So that all these consumers and family members who are also on the board, and I'm a consumer member, is that we understand what's going on. And when we are dealing with 5150s, I think it's called. Anyway, we do have members on our board who have the lived experience, so we go to them. And then we have members on our board who have never had that lived experience, who've always gone private. So that we have a full encompassing, and you really have to, it's hard to fill because we just lost 1.5 members and we're losing our board of supervisor member. And we're also probably in the process of losing another full-time member.
Now,
so our board is really short.
I wanted to do the mental health boards and commissions are huge. They're important stakeholders, but they are not the MHSA planning and advisory committee.
No, I know that.
So I think that's important for folks to know, because there are individuals, I should say not individuals, counties that have created their Mental Health Services Act Advisory Committee as a subcommittee to their behavioral health boards or commission, which is wonderful, because when they are under the boards or commissions, they fall under the Brown Act, and they fall under all the open meeting laws, so it creates greater transparency. But I do want to say that, and the mental health boards are kind of a obvious place to start if folks don't have a robust stakeholder process to create a board. I encourage that. So I'm happy to hear all your input, but I do know that what you're experiencing is not just unique to Siskiyou, that there is, it's hard throughout the state to ensure that all those seats are filled, and that they are also following the 20% family, 20% client, 10% client or family rule as well.
Yeah.
I do see, Pamela, your hand's been up for a little bit. Weston, did you have something you wanted to add?
Yes, I had put it in the chat box, but basically, without quality improvement and quality assurance, then we don't have the ability to leverage in dealing with contracts. So a key strategy is to ensure that we attend the quality assurance and quality improvement, because they go over their programs, and it's a key place to have evaluations and to bring forward the general standards and ask about the budget and see have they enhanced, and especially with innovation, our county did what they had always done, but when I specifically asked for activities like the Mental Health Oversight and Accountability Commission asked Dana, which is our prevention and early intervention, and one of our Prop 63 things, they said culture was eating food, and they talked about outreach, but it's not engagement activities. So becoming focused on going to those meetings, the quality improvement meetings, then we'll have a direct place, because they also deal with the appeals. And as you've said many times, for the ombudsman to investigate, there has to be that process with the county. So if we could also focus on finding out when those meetings are, bringing awareness that we're there, and then letting them know that we know about funding streams and that it can't be used to do what they've always done before. And that even the state auditors looking at, they only can have 30% prudent reserve. That's where we could also focus in, is going to those meetings.
Absolutely. Thank you for that, Pamela.
You're
So we only have a few minutes left, so I'm going to, I wanted to let you know that on the horizon, we do have our subject matter experts, our access ambassadors, that folks can always reach out or visit our website to find out who is your ambassador for your region if you wanted support and education in your local level. We are also going to be having our annual State of the Community Report conference in Oakland this year, and we are securing those dates, so they will be to be announced shortly, but that will be taking place in August. We offer on-call technical assistance to folks and county and leadership in the state. We are going to be visiting all regions throughout the next year in California, offering our supports with outreach and engagement, as well as providing education for our leadership and our stakeholders. So please stay tuned. Dates are continually being nailed down, and I always wondered why somebody didn't do something about that. Then I realized I am somebody. Thank you all for your hard work, dedication, and advocacy. And I look forward to seeing you throughout the state or hearing from you in our next webinar. Thank you all and have a great day.
Thank you.
Thank you.
And thank
Thanks.
you for all the historic background so that we don't have to figure it out. It's already written.
You got it. That's what we're here for.
Yeah,
Bye.
thanks, Andrea.
Thank you.